Hi, everyone. Welcome to the Midlife Wellness MP podcast. My name is Kim Hefner. I'm a board certified family nurse practitioner. I specialize in the midlife and menopausal woman, and I'm the host of this podcast. So, welcome. Well, recently there has been a bashing campaign on the use of niacin. And my guest today is a leading expert in the use of niacin, and he wants to set the data straight and the record straight on the use of niacin so that people experience all the benefits from it. He is a scientist, a lipidemiologist, and a researcher. His work is nationally known. His protocols have been used by physicians everywhere. His resume is extensive. So I'm excited to welcome Stephen McConnell to the podcast. Welcome to the Midlife Wellness MP podcast. How are you today?
I'm good. I've had a lot of luck lately, and my only break today will be to put these on if there's no clouds.
That's right. That's kind of
It's
cool.
going to be rainy and cloudy.
Yeah, I'm excited about the eclipse, so I'm looking forward to that. But I can't wait to talk to you about niacin
Okay.
because obviously, as you
Excuse me.
know, in the recent news, there has been some sabotaging of niacin going on and saying that it's associated with increased risk of cardiovascular events. So how would
Right.
you respond to
First
that?
of all, causality is everything. There's no causality in that study. And in fact, they didn't directly connect niacin to anything. They went after a metabolite. There's two metabolites, 4-PY and 2-PY. Well, if you actually look at the literature, and I got permission to obtain a big publication from researchers in Japan, they showed it was beneficial. It reduced inflammation. It reduced fibrosis and kidney disease. Now, that's kidney disease, but kidney disease is a vascular disease primarily. And unless you've got an exotic form, you got hypertension, uncontrolled glucose, even pre-diabetics become a CKD. Well, if you can benefit kidney disease with niacin, why are they saying it's deleterious? And the very markers they said, the 2-PY and 4-PY worsened, absolutely go down on niacin. And I don't know what they're thinking, who these brilliant men were. One of them argued with me online, but it's a PhD in California. And quite honestly, I'll be kind. I'll say he's less than intuitively bright. He's thinking like this. Anyway, when you look at the niacin literature, one of the targets, and there's many inflammatory targets and oxidative markers like myeloperoxidase. Niacin lowers them all. Well, let's talk about the study. They claim VCAM went up. No, niacin showed at least 10 studies VCAM went down. And some of the most famous people like Modi Kashyap and Dr. Robert Saperko, Robert Saperko, his wife Brenda, you name it. Brad Bale, I don't know if you know him. Him and Amy Doneen are partners and friends of mine. We're all big niacin freaks. Why? Because the same reason that got me into lipidology 22 years ago. The smartest guys in the business were using it, and they still use it, and they take it themselves, and they've got really low hospitalization. I got that kind of data. Blue Cross Blue Shield in Pittsburgh, Highmark, looked at the first 5 years of my very first two lipid clinics, one in Clarion, Pennsylvania, one in Erie, and our hospitalization dropped to almost nothing within 6 months of starting the lipid clinic. All the angina patients were angina-free and stayed that way for the entire 5-year analysis. We had the lowest code use in Western Pennsylvania. Why? Because we analyzed 35 codes and compared it to the 4 million insured lives and our several thousand insured lives under Highmark. And it was dramatic. All we really did is ordered better biomarkers. It's a key here. Don't rely on LDL. Don't rely on creatinine. There's a few that are totally obsolete. The societies have known it, but guidelines take 20 years to move a finger, right? So we saw that our code use was scant. I mean, on the spreadsheet, you could tell who my doctors were, even though they blinded the names, but they had the zip codes. So I went right to the zip codes, 16505, 16412, Clarion and Erie. And it was like strings of zeros under every code. And we were 27% lower for cabbage, open heart. That's what I was originally trained to work in. Stent placement was more than 50% lower. And carotid endarterectomy, it's a nasty surgery. They shouldn't be doing those.
Mm.
I think it was 74% lower. 5-year period, big N numbers for the comparator. Now that's kind of an epidemiological study, but it's vetted through the server in Camp Hill, which is near Harrisburg. And that's where the big database is for Blue Cross Blue Shield of Pennsylvania. And we knew we had something, but it was just anecdotal. We observed it, but no one else could see what we had done. And the head of informatics and statistics has since retired, but he was blown away and he was disgusted that they wouldn't act on it, because this is before pay for performance. There was no way to generate revenue off of prevention. And we're still struggling with that, although a lot of people give it lip service. So long story short, and I have a difficulty shortening things. Now everybody's interested in that, but I can't get anybody to talk to me because they follow things rigidly. But you're doing the same thing you did before you started an ACO, before you enrolled to do pay for performance and get shared savings. You haven't changed anything. You're using LDL, you're using creatinine. You think the only thing that works in cholesterol is a statin, and they don't realize that some people are harmed with a statin.
Mm-hmm.
So how are you convincing somebody when they have their ears covered? It's like the three monkeys: see no, hear no, speak no evil. Well, it's he no, speak no, hear no facts.
Right.
Sad.
Well,
But I have a lot of cohorts who are buying into me now, and they're realizing this is real stuff. Sorry.
No,
Go ahead.
you're fine. You're fine. I was just going to ask you, what would the motive be to, keep niacin in the dark? What
Well, niacin, we'll get off the pay for performance. It's probably greed. Why? It's 5 cents a gram. It's difficult to use. You got to have somebody that does it every day, or your compliance with your patients is going to be horrible. That's what we saw back in 2003. And the staff at one of the offices just were looking at me with darts, and they're all girls. And Dr. Davis stepped out and finally said, "Man, you better fix this. I can't keep the girls away from you very long." They were angry because they were getting nasty phone calls about the hot flash. They call it flushing.
Right.
So I remember I read this thing that Castelli had published, and I had his email. Really great guy. And it turned out him and a lot of these old timers all did the same thing. They used an aspirin, but it was much more clever to use it in the form of Alka-Seltzer. No dyspepsia. It's buffered. It hits you way quicker than an uncoated niacin or aspirin under your tongue. You got to use a 325, not an 81 milligram. And because it's aqueous, it's already dissolved. Boom. I think the alkalinity helps because it's not just dyspepsia, but it might actually get absorbed quicker because the stomach is acid. Who knows? All I know is I'd heard that applesauce worked. Everybody said 3 tablespoons. I made a tip sheet. I'll send it to you. It's called the Alka sauce, ALKA sauce protocol. And the patients would all look at it and go, "What does that mean?" Because they recognize the Alka. And they said, "Well, Alka-Seltzer is an aspirin. It's easier to take. And the sauce is applesauce." Oh, it's single page, 3rd grade reading level. You can't screw it up. So I was a bit of a coward because those girls looked like they were going to, I won't use the term, but I would be a eunuch when I left the office. They were pissed off. And I walk in, it's probably 6 weeks. I was actually afraid of them. I'd only come in when they left and Dave was doing paperwork and getting ready to come home. But I came in and I'd had a pretty difficult day because I was promoting this prescription niacin, and that's not an easy job. But that's how I learned this. And I quit working in the marketing side, was because I realized how underutilized and how underestimated it was, and the challenge of using it. So I came in with the tip sheet and disappeared for 6 weeks. So when I came back in, Jen, the office manager, stood up, put her hands on her hips and said, "We haven't anybody call in a whole month." Well, I'd had a horrible day and I wasn't connecting. And I have mild Asperger's and kind of have to hit me in the head with a shovel to get my attention sometimes. Ask my wife. Um, and Dave goes, he doesn't have a clue what you're talking about. But she goes, oh, nobody's called to complain about a hot flash for a whole month. And it kind of washed over me like the vision at Lourdes, or, I just saw a miracle because I knew that was a big deal. And Dave goes, no, no. He says, I didn't pull back. He goes, when I saw the sheet, I thought that's got to work. If it doesn't, whatever. So he started putting 30 or 40 people a week on niacin, which is a form of niacin. And I thought he increased prescribing and the complaints went down to zero for a whole month. I thought, that's how you do this. You beat the flush, you titrate them without a lot of interruption or quitting. And then the miracle unfolded. That's when we started seeing a month, 2 months, 6 months, no admissions for acute coronary syndrome, chest pain. And the ones that already had disease and had chest pain were all freaked out because they hadn't had chest pain in 2 or 3 weeks. And Dave handled it wonderfully. He just, told me, you call me back if your chest pain comes back. Keep your necklace on with your nitro, and he knew damn well there wasn't going to be any more phone calls, and there weren't any. And then the admissions dropped, and we could document that, but we wanted hardcore evidence. It was an act of God. Somebody from Highmark knew somebody else who I knew, and I ended up getting permission to go in there. They had to give me a magnetic card with an ID with my picture. It was like Fort Knox. And I get to know Brian Day, the director of informatics and statistics. He's on the same floor with the CEO and all the VIPs. And he was blown away when he got the data. It took a while. It was 2008 when we submitted the final data request. And by the end of 2009, we had the data we needed, because initially they didn't give us Medicare data. Come on, that's where most of these people are, older people. Well, we kind of bathed in that for a while, and I couldn't monetize it, so I kept working for industry, but I eventually became a medical science liaison in the laboratory industry, but primarily labs like Berkeley Heart Lab, Boston Heart Diagnostics, Liposcience, HDL, which was the gold standard, in my opinion, pretty close to Boston Heart Diagnostics. HDL became True Health, and my job was to ride around with reps and drive business, which is kind of tacky, but I didn't do that. I just explained to the doctor all the biomarkers that they didn't order or were uncomfortable ordering, what you can use to treat it. And I had clinical experience, and with the mother of all therapies, which was niacin. And when they realized you want to make those biomarkers look better, embrace the niacin and don't do it yourself. Have me train the MA or nurse, or if you actually have a coach, dietitian or a CDE come in, turn her into a medication coach, not just a lifestyle coach. I don't have a lot of faith in lifestyle. It usually doesn't get done unless you've got a rare population that's compliant. And Costelli said that they have to take to therapy.
You hit
So
that.
I focus on therapy.
For lifestyle.
And you know what? He was right. And I've noticed if the lab work is suddenly dramatically improved, particularly if they have a lot of reds, because I like colorized, the patient gets the colors, it saves time for the doctor. Well, if you had 10 or 15 reds, now you got one red and one yellow, you're going to notice that to the patient and the doctor. And then I go, you might want to relook at your lifestyle. Well, now they have confidence because I give them the credit. You did it, not me. I'm just a coach. But I know how we're going to get there, and I kind of have to set their expectations and walk them through. It takes an hour on the first encounter. But if they stay on the niacin for a week or two, everything else is easy. Fish oil, that's easy. Most of the medications don't have the magnitude of side effect. And the beauty of niacin is if you're compliant, it goes away. At the very least, if you're like a redhead like me, fair skin, it'll be mild. You won't notice it. Besides, you know how to get rid of it. Keep an Alka-Seltzer in your purse. or your wallet. There you go. I
Let
have
me
people call me. Go ahead. Sorry.
Well, I wanted to back up just a minute because for those of the people, we know about niacin because we're in the field, but for people that don't know what niacin is, could you talk a little bit about what niacin is and why we should care about niacin? And I know you've called it the Swift Army knife. So maybe
Yeah.
just talk about what niacin is, what it does, and why you call it that.
Great. Well, first of all, I'm not exaggerating. I didn't know half of what it did up until 10 years ago. And then I committed myself to researching these other disease areas, neuropathies, neurological diseases like ALS, multiple sclerosis. I have a friend who has Parkinson's. He's doing better because he's taking niacin. Well, let's
Wow.
step back. Niacin is a B vitamin. They call it vitamin B3. And don't confuse real niacin with no flush niacin or NAD. You want a cheap form of NAD? Buck up, be a grown up, not a baby, and learn how to take plain niacin because you get the whole miracle, not part of it.
Okay.
And it's because niacin goes to the liver and turns into NAD. It's amidated. The liver amidates it. Now you've got a form of nicotinic acid that's amidated. They call it nicotinamide or niacinamide. Now it doesn't do anything to the cardiovascular receptors per se. It works at a subcellular level, repairing mitochondria, sirtuin-1. It converts the nasty M1 macrophage. That's the white blood cells that eat pathogens. But when they're active, they're causing inflammation. I wish Cleveland Clinic would actually read some literature that they never knew existed. And it turns them into M2s, which are anti-inflammatory. Well, neurology, what does it do? It picks up the debris from damaged myelin sheaths. I tell the patient it's like a lamp cord and the insulation's been damaged, so you got bare copper. We don't want to touch it. You'll get electrocuted. Plus, it's short circuiting. Well, that's kind of what a nerve ending happens to it when it's damaged. Well, niacin removes the debris and then brings in these M2 macrophages. And through some mechanisms they're studying now, it repairs the myelin much faster. If you have a stroke, after the stroke, you take niacin, it restores brain plasticity, accelerates the repair of the damaged areas of the brain. Most of the metabolites that come off of niacin are absolutely essential for neurological health, particularly your brain. And the statement that helps you understand the breadth and the width of its benefit is there's 400 genes in the body that absolutely require niacin for normal function. Put that in your pipe and smoke at Cleveland Clinic. You don't even know this stuff. I guarantee you. If they do know it, shame on them. Then what they did was worse than ignorance. It's wonderful medication because Modi Kashup's a friend of mine. He's famous. He's at the VA system out in California. He's 83 and he's sharp as a tack. No question niacin is associated with that. I know a lot of these 80 plus, 90 plus scientists and doctors, and they're sharp as a tack. Well, they all take niacin. I don't know if that's why, but it doesn't hurt. It does contribute. Anyway, he helped develop niaspan. He's got a patent for fatty liver to the FDA, but he can't get financing to get it off the ground. Some brilliant billionaire needs enough money to get it back on the market. And that'll help clarify everything they did wrong. If you get it back on the market, everybody can slug it out, and the ones that haven't read anything are going to lose every time. They're going to be black and blue. And I always used to say, if you put me in the room with two axes and somebody who's claims he knows everything about niacin and thinks it's dangerous or doesn't work or whatever, if somebody's going to come out alive, it'll be me, because I have all the facts in my head. Thanks to little Asperger's, I have good retention. And niacin's just, it's like God's got a sense of humor. If you don't believe that, sit on a park bench and watch people walk by all day. Duh, he made us, yet look at how screwy some of us are. He's got a sense of humor. And that's why you have a hot flash. And I joke around with these.
Let's talk about that because people might not know what you're talking about when you say hot flush. But
Sure.
I remember back in my training, niacin was really in part of the training, and then it seemed to have fallen out of popularity for its use. And I think it was because of that side effect of people having a hot flush.
Oh,
But what I'm understanding is you feel like there is benefit to that. I mean, so
oh
I would love
yeah,
for you to talk a
absolutely.
little bit about what that is, why that's happening, why it's beneficial. And then maybe we could talk about what people should take, what form of like, is there a
Oh
certain
yeah, yeah.
brand? Is there a dose? Is there people that shouldn't take niacin? So maybe we could work through just a little bit about that so that people can really understand what they need to do.
Okay, your job, I'm kind of kidding, but is keep me on task. You'll be the on task cop. You can interrupt me at will, and it's hard to insult me because sometimes I don't know when I'm being insulted. Thanks to Asperger's,
And
I
you're
just
not going
smile
to
and
get
nod.
insulted here. No.
Niacin stimulates several pathways. The three that we know, and most people don't know more than one, is prostaglandin. Aspirin inhibits prostaglandin. The only over-the-counter pain reliever, they call them NSAIDs, non-steroidal anti-inflammatory drugs. The only one that doesn't is Tylenol. All the others do. Aspirin might be best, but I'm not sure. You got to take enough, which is standard 325. Well, the other two are serotonin, a serotonin pathway and a histamine pathway. Well, Dr. I got to get his name right, Theo Harris Theoretes, wonderful person. I couldn't afford to download a pay for copy of one of his publications using flavonoids. Turns out he had a lot of women with interstitial cystitis. That's what gave him name recognition. He does lectures on it. And his big go-to is flavonoids. Well, I don't remember the cause and effect, but he had patients on niacin, women, who were not having hot flashes. Well, that's how I found out. My wife needed something other than Cipro, which made me angry when they prescribed it, because women, a lot of women get interstitial cystitis. Well, it's largely inflammatory, and flavonoids are wonderful. Well, he discovered not only did it work better than aspirin, but it solved a problem for me that Dr. David presented me, which was, what do we do with the Coumadin patients? Most of them are on Coumadin because they had ischemic heart disease and I can't give them an aspirin. I'm like, holy crap. He goes, okay, bright boy, solve that. It was like Fido, fetch. And then, like a coward, he just jump into an encounter with a patient so he didn't have to keep talking to me. It stuck in my head, and here I'm solving something for my wife. And it turned out to be the solution why you flush and how to get rid of it. Well, quercetin, or the better absorbed, um, I think it's an isomer, isoquercitrin. They both work. So does luteolin. Almost anything that's antioxidant, anti-inflammatory, in particular the flavonoids, work. And he had two papers that came out. And it turns out quercetin works better than aspirin, but you have to be on it every day. Well, that's not a problem if you have a biomarker that needs corrected, and quercetin is particularly good at. Myeloperoxidase, it's a marker for
Okay.
unstable plaque. Um, any oxidative state, reactive oxygen species, inflammation. It lowers LDL because it raises the LDL receptors, which are really ApoB receptors. Boy, did that rock my world. I can add that on to somebody's niacin, and maybe they couldn't take enough to get the bad particles down, and give them a quercetin, it comes down another 5-10%. So does berberine. And it turns out berberine doesn't work very well because it's not well absorbed. And milk thistle and a list of other things, I'll send you the list, modulate P glycoprotein. So instead of 3 to 5% getting into the cell, you get 50% into the cell. Whoa! I use quercetin as a substitute for metformin. If you take a little milk thistle with it, it works like a charm. No side effects, no gastrointestinal distress, and it does 10 things that metformin doesn't do. Now, metformin is a miracle drug, but if they
Right.
had a patented prescription form, I'm sure it would eclipse what metformin does, in my estimation, based on 100 papers on berberine.
So you're
Now
saying
back
take,
to
oh, on the quercetin, you're saying take that with milk thistle, and
yeah,
that will.
Well, milk
Do what?
thistle quercetin modulate P-glycoprotein. That'll enable
Oh,
whatever compound is being blocked by P-glycoprotein to better be absorbed into the cell. And there's a list of stuff. That's why you have to
okay.
take curcumin, turmeric with zinc when you have a virus. Otherwise, the zinc doesn't get into the cell. And a friend of mine, Tony Osco, he owns a lab that's one of my partners. Great guy. He's actually a clinician that became a lab owner. He said, you got to take the turmeric. I know a lot, but I don't know everything and never will. And I pick up these things from people who are a little nerdy like me and they've already read it. And I'm like, wow. And then I'll go find 100 publications tangential to that. So back to the flushing. You get three things that kick up. Prostaglandin, there's a stimulus in the serotonin pathway and the histamine pathway. Well, aspirin is the go-to. Alka-Seltzer is a better form. It's aqueous. You don't have dyspepsia. And after 2 weeks, you're not going to have a hot flash anymore. Now, this is important. Women know what a hot flash is, but they call it flushing. You turn red or you get itching, the hair stands up in your arms, whatever. And it puts people off. And 90% of them quit the first day if you don't know what you're doing. I don't proclaim to know what I'm doing, but I know a lot about it. And I might have 5,000 people on niacin since I first started. I lost count. The trigger, the prostaglandin, doesn't necessarily make you have a hot flash if you don't suppress it. It's important. It's really important. I'll send you a Dropbox folder. I think there's 50 papers in there. It's a small Dropbox folder, but it's targeted at the downstream effect of the prostaglandin metabolite. And it's J2-dehydroxy prostaglandin something, big long name. And we just refer to it as the J2 metabolite, but it also has a cofactor. Downstream, you just got a robust effect on PPR gamma. In fact, prostaglandin's metabolites are the most potent ligand that's naturally found in the body for PPR gamma. And then that stems off. It's like 4, 5, 6 beneficial effects, lipids, glucose management. People think niacin causes diabetes. No, it reveals insulin resistance because there's a brief disruption of glucose management. But the big brains know at 6 months, the A1Cs come down 1/4 to 1/2 point. How many people know that? I'll send you the folder on that. It's brilliant because they gave it 6 months. They didn't pull the plug the first day. That's most people do when they see the glucose go up. And you can't give it fasting. That's
Okay.
the main problem. If you take it fasting, there aren't a lot of sources of fuel for the body in a fasting state. And in a ketogenic state, that's a much more favorable milieu for the brain and the heart and everything. In fact, they prefer that. But while there's still some amount of free fatty acids around, there usually is because it leaks out of your adipocytes. You have to have like 0 abdominal fat to not have free fatty acids fasting. So they're there. If you're insulin resistant or diabetic, they're very elevated, even when you're completely fasting. Well, niacin drives it to 0 and holds it there for about an hour and a half. That's a big problem because that'll exacerbate the insulin resistance because the rebound after it goes down is much higher than the baseline, way higher. That exacerbates insulin sensitivity. And when you're fasting and you take niacin, there's a brief hypotensive episode, lowering of the blood pressure. It's chronic and desirable long term, but you don't want that happening an hour before bedtime with niacin. That's why they screwed everything up. I admire them for bringing research dollars in, but the protocol was bad. It's 1/3 lower than the lowest recommended dose of the grandfathers of niacin, like Castelli. Got to take 3 grams or more. And what happens is the hypotension is much worse, and you get dizziness. The heart races to compensate, Starling's law. It beats faster to maintain the blood pressure. And if you're compromised in any way, that's not a good idea.
Right.
And if you look at the data, the catecholamines go up, but only when you take it fasting. But what happens if you take it with food? Just the opposite. There's an improvement in insulin resistance before 6 months. There's hardly any measurable negative effect on glucose by the first or second week, because now you've equilibrated. The prostaglandin goes up, but you're not having the hot flash, and the hypotension is much subdued. I know this because my wife has, what they call POTS,
Oh yeah.
and she has the most common variety, partial dysautonomia. It's almost completely a female population. Well, she was taking niacin fasting all at once at bedtime instead of small divided doses. Smaller divided doses equal the same big dose, but there's less problems. You just have to be compliant. Well, her Lp(a) is in the 5th percentile, horribly elevated. Top 5% of all the people with Lp(a). And I'm imagining being 60 years old and a widower. I can't have it. I love her dearly, but she's Sicilian and very stubborn. And I thought, God, this is the mother of all compliance issues, because she was not happy with me when she took the niacin. That lasted about a hot minute. Literally, she got a hot flash. So I realize now what I didn't then, and I started to realize that about 10 years ago. And when I solved the hot flash problem, I also solved the compliance problem. And when Dr. Tobias Kroon in Europe, I think he's in Denmark or Germany, I always get it confused because the email says .de at the end. It's actually Germany. Anyway, brilliant. He got a bunch of mammals, cannulated them, gave them the food through the cannula, and then introduced niacin before, during, after, tried every variation. Turns out the insulin resistance wasn't provoked when they did it while they were feeding, and a whole bunch of stuff, way more beneficial, easier to administer. And so now we realize, at least the people that still believe in niacin, that if you give it like they did 40 years ago, 50 years ago, a little bit with each meal, they do great. And a lot of really brilliant people that are friends of mine kind of argue with, why titrate? And I just slam them on. I'm like, you don't know what I've been through. And if I start them all the same way, some just, they go through the titration in a month. Some it takes 13, 14 weeks, like my wife. But she's doing 4.5 grams. God bless her. She's a champ. Wow. And you're unlikely to quit when you make all these little mortgage payments on your niacin, so to speak, and you've been through the process. And then the moment is when they get the next set of blood work. And I have to play dumb. How much are you taking? I know how much they're taking, but I want to hear them say it. They go, oh, that's all? You're only taking 3, so you're doing 1.5 grams, but 500 with each meal. And then they see the lab work and their head explodes. They get quiet, because it's a moment. I used to just look at the lipids.
That seems like a lot. That seems like a high dose. Did you say 3 grams? And then you're up to 4.5 grams? That seems like a lot.
Every niacin trial until niacin came out was robustly effective. In fact, the average dose in the HATS trial, which was only 3 years for a randomized trial outcomes, with an average 13.5 milligrams of simvastatin. That's a very low dose. Mm-hmm. But 2.4 grams of niacin, they tried the sustained release, they had problems. I don't use it. And they went back to immediate release. But they'd already been on niacin, so it was an easy flip back to plain niacin. 90% relative risk reduction. Beat that in any lipid-based outcomes trial. You can't even get close. The absolute risk reduction was 30 points.
Wow.
Most of these statin trials are 5, 8, maybe 10 or 12. And the number needed to treat was less than 4. Less than 4. Now, you take the cost of that therapy and run it out 3 years, cost of those 2 medications times 3 years, times 4, I think it was $5,000 to get rid of a heart attack. Now, to the novice or the layman, you got to understand they were treating a large number of people. But how many people do you need to treat for 3 years to get rid of a heart attack? 4. The PCSK9 inhibitors, Repatha and Praluent, require more than niacin in the niacin monotherapy trial. Niacin was 27, and I got that. I had different quotes on that, but Soterios Sam Zemeckis in San Diego is the only guy you should listen to about Lp(a) and niacin, because he does more research than anybody else in the last year than the next 10.
Who is
And
that?
he's a big, it's Soterios. I'll send you his contact file. Just email him and
Okay.
say, sorry to bother you, Steve. Gave me your email. I hope you don't mind. But he'll fill your head with facts and, equally important, clinical experience going back 30 years. He loves the quote. He's got guys with Lp(a) through the roof. They're alive after 30 years, alive, no events, and doing well on niacin. And it's important to realize three numbers that never get talked about. Absolute risk reduction. Placebo had 25% event rate at the end of the trial. The medication, usually a statin, dropped at 5 points, so it's 20. Well, 5 divided by 25 is 20%. No, that's relative. It's relative to what? It doesn't mean anything, not really. It's 5 points absolute, ARR, absolute risk reduction. Well, you divide as a decimal 1 by 0.05, 5%, 5 points, and you have to treat 20 people. Well, there's very few statin trials where you can treat 20 people and get rid of a heart attack, even if one out 10 years. And sometimes they get the number of subjects in the trial way up so they can show a benefit. And God bless them. I forget what his name is. He's a Ridker. He did a lot of data on C-reactive protein to establish that inflammation was as important, maybe more so, than the lipids themselves. But the one big giant trial, he had to get such a huge number because he needed a large N number to get statistically significant relative risk reduction. But nevertheless, he was trying to point out that whether the LDL was high or low, that the C-reactive protein drop created a benefit. That's the wrong biomarker to look at. It's acute phase reactant from the liver that signaled to you that something else in the body was at risk, and it told the liver and it kicked out C-reactive protein. You want something that tells you you've got a plaque that could rupture and cause a heart attack or stroke or cardiac death? Look at myeloperoxidase and the plaque test, which is LP-PLA2. I always run those unless there's a barrier to ordering it based on insurance. A lot of my providers don't do insurance. Go ahead.
So most people are familiar with LDL, HDL.
Yeah.
But what you're talking about are a little lesser known biomarkers. So LP(a), myeloperoxidase, and L-plaque2 activity, those are more to do with the actual what's going on in the vessels themselves as far as inflammation and plaque, correct?
I'll do those
and
quickly.
Okay, yeah. Just so
First of
people
all,
understand
LDL.
what we're talking about, because some people might not even know what we're talking about right now.
Forget LDL. Here, I'm going to use a roll of duct tape. It's one of my favorite adhesives. Okay, see the hole?
Yeah.
The theory used to be, and they still opportunistically take advantage of it, that the disease was cured by unblocking the hole or holding the hole open. Call that the patent vessel theory. Okay. And I heard a cardiologist who quit doing procedures, makes way less money, but he just couldn't look at himself in the mirror in the morning and continue to place stents. Stents provide no benefit. They hold the hole open. They don't address the wall of the artery. This is the duct tape. The disease in there, it's not in the hole. In fact, the lesions that they, like a hero, put a stent on aren't causing most of the events. 70% of them are tiny little yellow bump that doesn't affect the flow, but it's hot with inflammation. And when it busts open, like shoveling snow, getting out of bed in the morning, the plaque shears at the edge, lifts up, the cholesterol sticks out, and you've got a moving stream here. The clot, which is formed at that lesion, goes downstream and it gets bigger and bigger and bigger, and the arteries narrow, or you hit an obstruction, an old plaque that really wasn't causing any harm anymore, and catches. And I'll argue with any famous cardiologist, the only people it saves their life or prevents the event is the guy who's having an event at the emergency room. And they've proven this several times. Now, let's look at the particles. Well, I'll use the duct tape again. The cholesterol's inside. LDL's measuring what's in the particle. The particle's the bullet. If it goes through the lining of the artery, you got a problem. Well, it doesn't get there. The cholesterol doesn't get there without the particle. And they've proven a number of times, thanks to liposcience, that ApoB, which is all the bad particles, including the ones that came from the intestine, the particle number is useful, but it's a narrow spectrum of all the bad particles. But they showed in many studies, and it's no longer up for debate. It's no longer up for debate. If you use LDL, you miss at least 20 or 30 people at risk. Why? Because if it's high, you might be low risk. If it's high, you might be low risk. If it's low, you might be high risk. ApoB is never wrong. Now, it's the whole city of bad criminals. If you have small, dense particles, they're worse by a factor of about 4. And that's one of the best markers to spot insulin resistance. If you want to know if your blood sugar is bad after a meal, and you don't want to stick your finger and borrow a glucometer from your neighbor who has diabetes, or you haven't had a glucose challenge, look at your small dense particles. They're not expensive. If it's yellow or red, you're insulin resistant. And even these calculations that Boston Heart has and Quest and everybody, they miss a bunch of them. But the small dense doesn't, because you have to have insulin resistance to make small dense particles. Easy as that. What's worse than that? Well, equally worse is what they call remnants. Turns out the particles they used to ignore, VLDL, 1, 2, 3, IDL, those are much bigger and they descend and become an LDL particle. They're triglyceride rich, but the smaller remnants like VLDL3, IDL, actually get into the arterial wall. And now they know the remnants from chylomicron, which usually don't hang around very long, that came from your intestine. It's trying to get into the body. The breakdown particle, chylomicron, massive. They're 30 times bigger than an LDL, but they're mostly triglycerides and they don't hang around very long. But some people, they do. Diabetics, you name it. And the remnant is just small enough that it'll get underneath the artery. So why get bogged down in all that? Order an ApoB, order a small dense particle. You're going to get a triglyceride measurement or VLDL in the standard lipid panel. That has utility, but get the Lp(a). Why? Dr. Zemeckis observed that all his referral, when they come to him, he's in a hospital-based group, 43 to 48% of Lp(a). And what we saw with Health Diagnostic Laboratory was 53% in an exclusively cardiac rehab setting had Lp(a). Well, what are we doing about it? First, you got to measure it. Less than 1% of the people like my wife ever get it measured. We measured it 20 years ago and my jaw dropped. You wouldn't think to look at her that she had a risk factor. She was always skinny. I don't know why she was interested in me. I figured she was nearsighted. Anyway, I find out she's got Lp(a). Well, it's out there. It's half the events. How do I know that? Ask Zemeckis. Look at the rehab data. If half of them had survived, the survivors of a heart attack or a stroke are in cardiac rehab now, and half of them have Lp(a), what does that tell you? It's causal. We know it's causal because it's only 1 out of 4 people, and if you double that number are measured after they have a heart attack as having it, if they live. We don't know about the ones in a coffin. It's kind of hard to do phlebotomy on the dead person.
Exactly.
But,
so my
you
understanding
gotta
about
measure.
Lp(a) is it's got a genetic component to it, Lp(a). Is that right?
Completely
Not
genetic.
a whole lot. Not a whole lot in my experience from researching it really brings down Lp(a). But we were talking earlier that niacin actually is pretty beneficial at lowering Lp(a). And interestingly, as I research menopause, it rises as we go through menopause. Lp(a) can
Yeah,
rise. So this is good information for women experiencing that because our cardiac risk factors go up as we go through menopause. So tell
right.
me, niacin, you have seen benefit in lowering Lp(a)?
Right. Well, let's start with some statistics that tie into what you said. A male that carries the genetics. And by the way, forget lifestyle, exercise. I've got some famous, they do podcast guys, you're ketogenic, all the right diet, all the exercise, and they still had horrible disease all through their body. But they finally went to a smart doctor, one of my friends, and they had Lp(a). So she handed them to me because it's kind of a job and it's a dirty job, but I don't mind doing it. But that's why a lot of doctors like me, is because I'll roll up my sleeves and get them all messy, taking care of that nasty job. I enjoy it because when it comes down
Yeah.
30, 40, 50, 60%, that's a win. The risk just came down a lot. Plus, all the other lipids look perfect. They're way past goal because niacin's still the only thing that positively moves all the bad particles in the right direction, all the good ones up. And men, because it's genetic and lifestyle doesn't affect it, it hits a plateau at 7 months of age. Women, it hits an artificially low plateau. It's still elevated until they go through menopause. Why? Because a lot of the effects on risk factors with natural estrogen within the body and oral estrogen, because it'll go through the liver, it looks like niacin. And I know that for a fact because I watch women who discontinued it because of breast cancer risk, and suddenly their lipids went to hell, but they look great on estrogen. So I am a believer in hormone replacement therapy, but I think it has to be a doctor with a lot of experience and they understand all the potential risks and how to use it and what doses. Well, my wife's went up a lot, almost double, because she's 60 now, but I remember I had measurements on it 20 years ago. So I got to watch that whole transition and it frightened the heck out of me. Well, there are some meds that'll move it down a little bit. And there's some idiots that claim statins will lower 5 or 10%. Where did you get that? Your personal experience, which was worthless because you made the wrong observation. Statins increase Lp(a) a lot. Ask Dr. Zemeckis, he'll show you the case studies. And some people it goes up 200 nanomoles. That's 80 milligrams per deciliter. That's well above where you want them to be. Plus, it was somebody already had it, so it went way up. And they go, well, the LDL's low now. I'll keep them on the statin. And the famous guy at Cleveland Clinic went around and around with me. Now I think he realizes he was wrong and I was right. I don't care about me being right. I don't care about me getting any glory. It's you got to know what's going on. Well, Zemeckis actually will use a PCSK9 inhibitor with or without niacin, because if he sees that the statin provoked that, in my experience, it almost does it every time. It's just how much, hard to say. And some researchers in the Journal of Clinical Lipidology got the Lp(a) down 88% with 2 grams of niacin. But there's a caveat there. They didn't know how high it was at baseline when they already put the patient on the statin. Well, if you look at the graph, and I'll send it to you, it's very provoking because all the information's in that one stupid graph from the slide deck. It barely came down on the 2 grams of niacin when they introduced it, because initially you were on 40 of a statin. I think it was Lipitor, it might have been Crestor. And what they did is, for some reason, they read something or intuition. They thought, well, why is it not coming down more? And the LDL looked good, right? They didn't have an ApoB measure. But for some reason, because the woman was under the age of 35, I think she was in her 20s, she's had stents, a heart attack. Duh. That's the person that's got Lp(a). Well, they started titrating the statin down from 40 to 20 to 10 to 5. When they got to 5, there was an 88% drop in Lp(a), and the LDL was lower than 40 of the statin. I see it all the time. That's my strategy. If the provider, who's the patient's provider, is really just, okay, say, lower the statin dose. I promise you, give her a month and the LDL will be lower. Would that make you happy? Sure it would. but the LP little a will come down because statins increase PCSK9. Let me repeat that. Praluent, Repatha were developed to offset something horribly bad with statins, that they all raise they raise PCSK9. Well, there's several pathways for removing LP(a), and that's one of them. And LP(a) carries PCSK9. So it's killing the receptor that grabbed one lousy particle. Now it's not coming back out like it should, like a catcher's mitt, to keep grabbing particles. You just lost that catcher's mitt. And the higher the PCSK9, less catcher's mitt. Now you've lost efficacy on ApoB. The LDL is falsely leading you to believe there's a benefit because the statins only lower particles at the lowest dose. You get a 1% drop with each doubling of the dose, each titration. Well, what's going on? Why is the LDL coming up? Because you're making small, dense particles that have very low cholesterol. Aren't those worse? Yes. Statins increase the percentage of small, dense particles because they only remove the large ones that are the least dangerous. That's just a fact. It's inarguable. So why are you beating up with AD Lipitor when most of the work was done that benefited them, not just the LDL, at the lowest dose? Because the company told me to, and they tried to show me, no. The difference between the lowest dose and the highest dose is what they call the rule of sixes. So you get about another 6% with each doubling of the statin. So by the time you get to the highest dose versus the lowest dose, that's 18% decrease in LDL. Oh, wow, that's got to be beneficial. No, it's 1 to 2% relative risk. So 3 doublings, you get 6% relative risk. That's garbage. No benefit. The interesting thing is niacin at 3 grams works as good, if not better, than Praluent and Repatha. And Praluent and Repatha only lower LP(a) about 15 to 16%. Don't believe their press notices it lowers at 20%. And then they say, and niacin only lowers at 20%. I've never seen 20%. The lowest I've seen was 43, and that was with 2 grams. And depending on the patient and the dose, it's highly variable. My wife's came down 63%. I sent you the slide deck. There are a couple interesting graphics that might help this podcast, but you can maybe add them on later or whatever.
Yeah.
But
I think I
I have a graphic. It's called "What Does Good Look Like?" And on the right, almost everything's red, and on the left, everything's green. And they weren't like mildly elevated; they were horribly elevated. 2 grams of niacin, 10 cents worth of niacin drove it all the way into the green. And LP(a) is hard to get into the green.
Yeah.
You try to suppress a gene, but it doesn't just lower ApoB, which LP(a) is a subset. It's a portion of ApoB, but it hits several mechanisms. It actually does what these new injectables do. It suppresses it genetically. The gene, which they call capital L, capital P, capital A, the primary gene that drives LP(a) up. And it's only the small, lower molecular weight type it's raising. I've had maybe 5 patients out of 1,000 that had the high molecular weight type. Well, it's too big and bulky to get out of the liver, so you rarely see it more than yellow, slightly elevated. But everyone else, it's all over the map. It's a statistician's nightmare because there's no average. You're either 0 or really high, and it throws statistics off. And it's part of the reason they think niacin only lowers to 20%. But the fact is, never less than 40%. And there's a residual long-term additive decrease as you fatigue a number of different things. You're lowering the PCSK9. Well, that'll grab some of the LP(a). And if you're bringing it down slowly, well, there'll be a slow improvement in the decrease. And if you're suppressing the gene, that takes a while. Dr. Zyka, one of the first lipid clinics in Florida, and he was the founder of the first local chapter for the National Lipid Association. Really cool guy, my first mentor. He was very patient with me and helpful. He said it could take 2 years, then it might suddenly just drop all of a sudden on the last lab you're in after 24 months. So I remember that. But mostly, if I can get them to dose, I see most of the decrease within 6 months. But there's still sort of a residual benefit over time. And niacin's funny like that. There was no mortality benefit the first 6 years of that first ever outcomes trial using anything. The 2.4 grams average of niacin, they saw after they stopped it, and another 9 years, the placebo group was dying at 11% higher rate, and the statistical significance was phenomenal. A lot of cardiologists like to poke at that. Well, if I stop all your statin patients 9 years later, what's the mortality going to look like versus placebo? Horrible, about the same as placebo. Well, how did niacin do that? And it's the only one that did it. There was a fundamental change in the architecture of the arteries. They become more elastic, like when you're a kid. The distensibility, particularly in the aortic arch and the head vessels that come off of it. It also restores a lot of endothelial dysfunction. It makes a lot of nitric oxide, which is the end product of the prostaglandin that causes you to have the hot flash. Well, you need nitric oxide. Most blood pressure drugs improve nitric oxide. You want a lot, take niacin. That's why it's useful for erectile dysfunction. I won't get into the weeds on that, but it's pretty cheap. If your Cialis and your Viagra don't work that well, take a half a gram of niacin. You won't care about the hot flash if you even notice it. And two people are happier, not just the husband or boyfriend. But I have a cocktail for people.
Dangers to taking niacin? Is there any dangers?
Hypotension, peptic ulcer, chronic atrial fib. There's a few of them, but actually they found ways to getting around a couple of them. But the peptic ulcer, you'd have to take a enteric coated to get it past the stomach, and then you really wouldn't have a risk.
Okay.
With the atrial fib, I'm very cautious with that. But I have a few people taking it, it hasn't exacerbated it. And how do they get atrial fib? Diabetes, vascular disease. So, I'm helping them prevent a heart attack. They might have atrial fib, but if you're careful with it, you shouldn't have a problem. And my newer way to titrate, which is slow, very low starting dose, slowly increase it, only take it with food. It doesn't seem to provoke that, because if you take it fasting and you experience the full hypotensive effect, that clearly could exacerbate a negative thing. And, there's always a way to fix things. Since I don't have a practice, practices refer to me. When I'm not talking to patients, which is most of the time, I'm reading literature and putting ideas together. And then the braver doctors, particularly the ones that know me really well, they're totally fearless. Oh, let's try that. I say, where's your safety data? I said, here, read these 5 publications. But if you don't have time, read the abstract on that one. If you got time to read the abstract. And then they go, oh, I'm like Bill Nye. I'm Steve, the science guy. They know I read all the time. So if it's literature-based, that's evidence-based. Whether the drug company funded it or not, it's peer-reviewed literature. How much? There's so much literature on niacin, it rivals the statins, because they found out it's good for dementia and Alzheimer's. Niacin shrinks brain tumors, glioblastomas, brain cancer tumors.
Wow.
I think I know why.
If there's any, I was going to ask you if there's any FDA approved indications for niacin. And we've talked a little bit about kidney disease, cardiovascular disease. Are there any other conditions where niacin shines?
Well, indications are kind of hard to get. It's usually you're promoting a drug. So nobody's going to get the money to get a supplement to indication. However, niacin still holds the FDA indication to produce regression in cardiovascular lesions. What does that mean? You got a plaque this big and now it's this big. It shrunk. They say statins do that. They don't. You have to have pretty good HDL for the statin to offset the negative stuff, which they like to call LDL. But if your HDL species aren't in good shape, functional, and you don't have enough of them, you're not going to see regression. Well, niacin raises those which statins really don't, and lowers all the bad guys, and the worst of them, small, dense, and LP little a, duh, it's intuitive. Well, they did it without a statin. They had cholesterol and niacin. And to answer your previous question, I get off message, I apologize. They were using 6 to 12 grams with cholesterol. That's where they first had the data for regression that the FDA gave them the indication. They haven't removed that indication. Niacin caused most of the problems in the discrediting of niacin, but the indication for plain immediate release niacin, they call it crystalline, because when you crush the tablet, it shines. It's crystalline, you know? And they still say it's FDA approved up to 4 grams of crystalline. Yet they were using 6 to 12 in the cholesterol studies. And their target dose was 3 to 6 in the coronary drug project, but not very much was known about niacin. So they compromised by getting an average of 2.4. Well, clearly a lot of people weren't even getting 2.4, and a lot of people were getting more because they were doing good. But the benefit was 27% reduction in heart attack. This is the first ever outcomes trial. 24% in stroke. And diabetics, it was double. You can't do that with a statin or anything else. Like 56%, I believe, was the figure. Well, when you look at the lipids in a diabetic, and you see the same thing in pre-diabetes, a lot of small dense particles, high ApoB with the nominal LDL. Niacin's much better at that than the statin. So it's intuitive that if you have diabetes, and they have a higher risk rate. In fact, if you had a heart attack and you're not a diabetic, and there's a big study on that, versus diabetics who haven't had a heart attack, the event rate, the risk of an event was the same with diabetics because they're diabetics, even though they hadn't had the heart attack at baseline. Well, one of the reasons is it's the lipids that cause the event, not the blood sugar. It's mainly microvascular. But even that's affected by lipids. If you look at one of the slides I sent you, it's a graphic. You can just throw it up the screen if you want. It's the STENO2 trial. The amount of risk reduction controlling A1C well or controlling hypertension well was on the order of 12 to 15%. If you doubled that for both of them, put them together and double it, it was still half as much as the lipid control, which was 70% of all the overall risk. Way more important than blood pressure, way more important than glucose. Well, if you got bad blood pressure, you got bad lipids. That's how the lining of your artery got so sick that it no longer dilates and keeps your blood pressure normal. It's because of the lipids. It's lipotoxicity. Fix the lipids, you fix 70% of the problem. And if you actually measure the right biomarkers, you've got better targets, and your aim doesn't need to be that good. I always joke that niacin is God's shotgun or God's Swiss Army knife. And he invented it on Saturday night, right? Well, he spent the previous week making the sun, the moon, the stars, the planets, and us. And he was tired. Even God gets tired. He gets angry. We know that. Look at the Old Testament. Flood, And then he changes his mind and goes, maybe I was a little tough on him. Well, and he has a sense of humor. He invented niacin late on Saturday night. And he was like, oh, wow, boy, what a good boy am I. I came up with the best thing all week, niacin. And so what did he do? He said, I need a break. I'm taking Sunday off for the rest of time. I tell it to my patients. They always laugh, but they remember that because God made niacin, not Pfizer, not Merck. And he's not in the business of making money. That's why it's still less than 5 cents a gram. Right. But it went up a little with inflation. 1,000 half grams, 500 grams is $25. So it's right in there. And I always remind patients on the first follow-up when we get it's not the first follow-up, but the first follow-up where they got new lab work. I play dumb. How much are you taking? Oh, 1.5 grams. That's all? And then I shut up, which is difficult for me. And they go, should it be taken more? Is that okay? Can I? Well, I think the answer to all three is yes. But I don't know. It could cost you another 5 cents a day. And then I laugh because it's usually over the phone. They go, oh, and then they get it. I'm done. I'm done coaching them now. They saw why they're taking it. The follow-up lab work just looks tremendous. For years, I didn't notice the creatinine dropped. And don't trust creatinine. That's one of those biomarkers I have an issue with. They've shown that 27% were way worse than the creatinine said, and are almost exclusively stage 1 and 2. So what does that mean? Well, we all know from the renal societies, kidney authorities, that 80 to 90% never get a diagnosis until stage 4. But what does your doctor usually do? He gets frightened, sends it to the nephrologist. Is that a good idea? Not if you can reverse it, but that's what everybody does. What's the nephrologist's main focus? What's the agenda? I have an empty dialysis chair. Is he going to change your therapy in any significant way? He'll put you on Tums for your elevated phosphorus. He'll make sure you're on blood pressure drugs and diabetes drugs. And when that happened to my dad, I was just learning this back in 2003. He was 81. He had a heart attack. They put 3 stents in. I knew the cardiologist. He had calcifications everywhere. It looked like a diabetic because he took me back. And the other cardiologists were kind of disgruntled that some civilian was back there, but he knew me. I worked at Hammett and I worked in open heart. So some of them actually knew I had credibility. Besides, it was my dad. And I looked at the SIN and went, oh, this is horrible. He says, yeah, I could only get the 2 stents in the first day because it was so calcific and tortuous. He said I had to put the highest pressure balloon in to bust the calcium the second day because he's too old to do a long procedure. And then he was able to get way down on the LAD and put the last stent in, which of course provided no benefit, but it held the hole open and they were doing it a day after the heart attack, so it made sense. Well, he goes to Florida for the winter with my mom like they used to, and he ends up in open heart quintuple bypass, annuloplasty, aortic valve repair. He comes back to the lipid clinic. This is a year after the heart attack. They're back for the summer, and Dr. Dave says, oh man, he goes, I hate to tell you this, your dad's got renal insufficiency. He's in renal failure. And I said, what stage is he? I'm kind of dumb, naive. I thought doctors staged him. No, they don't. Besides, if they suddenly appear stage 4 and you never had any prior opportunity, they're renal failure. It's a pretty broad term. Well, he was scheduled for dialysis. He had to have his consult with a nephrologist, and I was angry. So I knew enough about it from Dr. William Finn, famous. He writes textbooks for the nephrology students. And when I trotted him around to do lectures, it was like, oh my God, Dr. Finn, what a wonderful guy. He said, there's a dirty secret in nephrology. He goes, we all know it, and we don't like civilians or other doctors to know it. It's like a secret handshake, like the Masons have a secret handshake. They hold their thumb a certain way when they're hitchhiking, and a Mason will pick them up. There's a dirty secret in nephrology. And he told me, he says, you're not going to like it. He goes, we're more concerned about morbidity than mortality. And I'm kind of a purist. I was like, why would that? He goes, I know, it doesn't make sense. He goes, well, if you get really sick, you're admitted to the ER. Now the hospital owns you for 2 weeks or 2 months. They got their own dialysis machine. You're scheduled 3 times a week for treatment. I have to keep that chair vacant till you come back. He said, I'm losing 3% Medicare margin money on every one of those visits where you're normally here. Now I can't bill for anything, and I can't put a new patient in there. If you die, I can put somebody in that chair almost immediately. Wow. I got sick. Now, it's not like I have anything against nephrology, but my publishing partner is in India, and he doesn't have that luxury. It's government funded. He gets a salary. He's not rewarded for filling dentist chairs. And guess what he does? Even though most nephrologists think I'm nuts, he puts them on sodium bicarb and calcium carbonate. Well, what is that? Calcium carbonate is Tums, and sodium bicarbonate is baking soda. It's just a more clean form of what you get in the yellow box that you hide in the refrigerator. And that's what my dad did. We took it out of the box and stirred it up because mom wouldn't let him start eating till he did what Steve told him to do. And I had credibility because within 2 months, he went back to stage 2. He was almost stage 5. That blew
Wow.
my mind. But it told me something, that those 3 things, he was on niacin already for the lipids, have a lot to do with what caused the kidney disease, and certainly caused it to reverse, because they took care of the hidden acidosis. The bicarbonate on a lab work is lying to you. It's like creatinine. It doesn't deteriorate to stage 4. Well, what good is that?
Right.
And the first thing they give the patient for phosphorus control is Tums, literally Tums.
Wow.
And you can get a cheaper form at Walmart sitting right next to the Tums. It doesn't say Tums, but it's calcium carbonate. And how could it be any easier? It's fruit flavored, it tastes sweet. And my dad did, I think, 2 at lunch, 2 at dinner. We gave him a teaspoon of sodium bicarbonate, baking soda, right out of the yellow box. Well, it comes in a pill form. You really should use the pill. They're easier to use, they're cleaner. And sodium bicarbonate's kind of nasty tasting. And don't worry about the sodium. Because it's bicarbonate, that's the metal, they call it a metal salt, and not sodium chloride. Sodium chloride will retain the sodium. Now you got an issue, edema, blood pressure. Sodium's dumped at a much faster rate when you take sodium bicarb, so the calcium, or excuse me, the bicarbonate sticks around, but the sodium's gone. And the bicarbonate improves the endothelial function. It addresses the loss of alkali, and it's hard to spot. You have to do a TCO2. It's a blood gas. Or if you can afford it, and it's not an inconvenience, get a urine catch and check the urine citrate. If they're low, you're acidotic. And some of the experts in the field, and I like following these guys, they got big brains, and I have temporary access to their wisdom, right? They say you should just give them the starting dose. It's in all the guidelines, KDOQI, KDIGO, American Kidney Foundation, National Kidney Foundation. Give them 1.8 grams. It's 3 tablets. It's really 1.95 grams, almost 2. It's 3 tablets, 1 at lunch, 1 at dinner. The acidosis is generated from the food. And American diet, highly acidotic. Well, you got to maintain your protein intake, and I'll argue with anybody about that, because one of the top 3 forms of mortality, causes of mortality, kidney disease, is malnutrition. They're not getting enough protein, and starving them.
That's a good point, because you used to hear if with kidney disease, you used to hear you should avoid high protein diet if you have kidney disease.
And there's good reasons for that. But the thing is, you offset the acidosis and the phosphorus. Niacin's way better than a standard chelator. Chelators have a feedback mechanism. What I mean chelator is you got a positive charge, it's attracted to a negative charge. Well, the sodium the Tums is calcium carbonate. The carbonate's kind of nice. It's alkali. It's good for you. But why they use it is the calcium has a double positive charge, and it attracts these phosphorus ions, which are negative. Phosphorus is toxic, and the higher the levels are, the more likely you're going to have calcification, shutdown of the kidneys, mineral bone disease. So you got to get rid of it. Well, if you take calcium carbonate, the carbonate grabs a whole bunch of the phosphorus and holds it in the interior of the intestinal tube and ends up in your poop, basically. Excuse my French. Well, it's not getting absorbed, but it can't do all of it, and you can't overdo the calcium, and I won't get into that. But what happens is the body senses a loss of phosphorus that's not being bound by the calcium, and the receptors that pull it through the intestine into the bloodstream increase. So there's a drop and then a feedback bump up. It's not always there, but it does happen. So how do you defeat that? Well, you got to shut down those receptors. Guess what niacin does? It downregulates all of them. 1 hammer, 1,000,000 nails, 500,000 nails, it doesn't matter. Bang, 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 bang. Now they can't absorb as much phosphorus. The more niacin you take, the more closer to normal physiologic levels of phosphorus. And when you combine them, that's what Dr. Sampathkumar, my buddy in India, does. He's not getting paid for dialysis. He actually is trying to fix the problem. He puts them all in sodium bicarb, calcium carbonate, Tums, and niacin. And he asked him about the niacin. He's got 10 publications just on that. It's cheap. Everybody's pouring into it. He's doing better than the patient, but none of his patients have the money for drugs. That's why he doesn't even bother writing them. And they'll use Ayurvedic medicine first, natural, holistic, integrative, functional. I'm big on that here. That's why he thinks my thing's going to fly in India, because it's natural and it's cheap. And he uses niacin. He's been using niacin, but rarely goes over 500 milligrams. I changed that a little bit. Now he's looking at their lipids and trying to get their lipids in check. And we're collating his baseline versus follow-up, because we think we can keep more of his patients off of dialysis by more rigidly implementing all three. And I told him a few other things that, you got to rule out their subclinical hypothyroid. A TSH of 4 is not normal, particularly with a free T4 that's normal, because the thyroid's trying to hold them in a euthyroid state, a normal thyroid state. And most people on treatment aren't actually euthyroid. They're still slightly low. And a lot of people that are subclinical, they're slightly low, the provider won't treat them. He's afraid of overtreating them. And I have a friend, an electrophysiologist, that's angry because they don't titrate the Coumadin to get an optimal INR. So they're undertreating him and still have a blood clot. Why did you bother? He said, I'd much rather deal with them being admitted with a bleed than a blood clot in their brain or their lungs. And he goes, why do they do that? It's undertreating because they're the fear of overtreating because of the narrow therapeutic window. Well, guess what? It's way worse sequelae, results when you undertreat them than if you overtreat them slightly, because it's very difficult to cause, what do they call it? A thyroid storm, thyroxinemia. And there's a friend of mine in Florida who pushes them until their pulse races a little bit, and then he backs them down one titration step. He goes, now I know they're normal because I hit slightly elevated, saw the effect, told the patient to call immediately, and he already had in their hand the next lowest dose. And if they didn't have side effects, he might titrate them further. He's got, what? Huevos grande, big eggs. And I admire him for it because all his patients are optimal. He's one of the largest implanters of bio-T. He knows hormone therapy. He's a cool guy. I'll hook you up with him if you want to meet him. And
that'd be great. I love that because I'm all about hormone therapy.
Yeah, it took him 7 years to get back to me, but I put the idea in his head 2016 because the rep in the Pensacola area for the lab introduced me to him. His wife came and rep bought dinner, and I gave him the Tums and Hammer protocol. Tums, arm and hammer. Patients love that because they kind of recognize it. Tums, what's the hammer? What's the yellow box in your refrigerator? Oh, baking soda. Yeah. Say, look it up on the internet. And if they take it, it slows the kidneys down. And what they discovered with that very dose, the lowest dose, in a 2-year period, stage 3 and 4, they saw placebo, about a third of them were on dialysis. Pretty bad by the end of 2 years. They went to stage 5. But less than 4% on the baking soda ended up. And the nutritional status improved because they were doing circumference measurements of the biceps. And the baking soda, they were bulking up. They were recapturing their lost protein. Wow. And there was all kinds of neat nuggets from that study. One of them that's really important is everybody worries about the sodium. Blood pressure control improved in a segment. Nobody got worse. No edema. No increase in hypertensive medications. What does that tell you? The sodium is only a player based on what it's attached to, not thinking of it by itself. Because the behavior of the sodium is influenced by the other component of the metal salt. And a lot of people say, let's use citrate. Excess aluminum absorption is not a great idea with kidney disease. That's why they stopped using aluminum as a chelator about 30 years ago, because it gorps your brain and causes bone mineral disease.
Wow.
There was a huge argument about lanthanum carbonate being a problem, but not the same thing. It's just on that valence and the periodic table. Anyway,
Yeah.
I left my cursor in the wrong place. Where was it? So that combination is really cool. It's about 15 cents. Now, God bless him. Dr. Raphael is one of the people at the tip of the spear, not the last guy to read the paper. He's the guy that
Right.
wrote the paper. And Wesson and Tangri and Guraya. It's a huge list. I'll send it to you. They're the people following hidden acidosis. And they like scientific words. The scientific word is EU, eubicarbonatemic acidosis. Boy, that'd take you a minute just to write that out. It's hidden
Right.
acidosis. Don't trust the bicarb. Find a more accurate reflection of the alkali that's available within the body. When you start to exhaust the alkali, the last thing that deteriorates the bicarbonate. So you look at T, total CO2. Around 22 is not good. You want them like 24, 25, 26. No greater than 28. There's not a lot of risk pushing the alkali, and you can give them a lot before they become alkalotic. But and you look at the bicarb, you don't want the bicarb greater than 28. But the funny thing is, the higher you go with a sodium bicarb, you hardly see it move at all until you get them replete to the truly bicarbonatemic. And that,
I fear that people won't really understand what we're talking about because
I'm sorry.
no. I just like because it's probably
Yeah,
high
that's
level
my
for
fault.
people to really. But
It's
no,
my fault.
you're fine. I just
Basically,
don't want to lose people understanding what we're talking
acidosis,
about.
yeah, acidosis is a reflection of enough bicarbonate, too much, or not enough. Too much is alkalosis, the pH is up.
Yeah.
Acidosis is pH is low, and it's really tiny amounts are bad for your kidneys and the whole body. And the American diet makes it worse. So,
Right. That's true.
what do you do if you know you're acidotic? Well, sodium bicarb's cheap and it works like a champ. But treating it doesn't make the numbers move around very quickly. So there's no real threat of overdosing. I mean, there's a nice protocol that was in the 2024 KDOKI or KDIGO, and it's a huge document. I think it's 80 pages, but they were very clear why to do it, how to do it. And they used Dr. Raphael's grid, which is wonderful. It's like a guide to using bicarbonate for kidney disease. You start off with the 3 tablets. It's 1950, 1.95 grams, almost 2. And then he doubles it, triples it. He gets all the way up to pretty high dose. I think he was using, if I remember correctly, he was going up to double that 1950 2 or 3 times a day. But he did it in a very measured, sensical manner, and with safety in mind. The TCO2 has to be X at start, or you're just giving them without blood measurements to the 1.95. That's not going to hurt them because a lot of it will come out as citrate in the urine. So that's the compensatory mechanism. You might put too much sodium bicarbonate in the body, but if it's more than enough, it'll come out the kidneys. The TCO2 will eventually go up. So now you know you're where you belong. If they don't respond, they needed more. And it's easy to follow. A patient could administer themselves with that grid. And you're not going to harm your body taking 3 sodium bicarbonate tablets. What do people do for years of sodium bicarbonate? Calcium, baking soda. You got a sour stomach, too much acid. They'd stir up a couple teaspoons. That's a lot. Didn't kill them. And it got rid of the dyspepsia and everybody's happy. Well, now we realize how beneficial it is. It's one of the go-tos for kidney stones. Same thing. And urine citrate's the marker of choice to evaluate the presence or the risk of kidney stones. So you don't want to be acidotic. An easy fix is sodium bicarb. I don't recommend going off by yourself. You need a provider or a nerd like me to guide you through it. But if they haven't read anything, they're not going to do much more than they would have done before. And they probably didn't even know you had loss of kidney function because the creatinine will lie to you until you're stage 4. And there's 6 stages, not 5. They say 5, but it's actually 6.
Wow.
Why? There's stage 1, stage 2, 3A, 3B, and 4. And one of your questions was where I'm going with this. I finally got lucky. I found a bunch of people that actually are credible and famous, so I don't have to argue my point, and I'm not even a licensed provider. I'm just a scientist. But why do a couple hundred doctors send me patients? Because they get the job done that they don't have time to do, or they don't have the experience, or it's niacin, and ooh, that's scary. But they appreciate niacin, but they know that I do it all the time. So why not have Steve do it? Patient pays me, doctor pays me. I used to do it for free till my wife got all over me. And she's right. I was just too shy to ask for money. But I like doing the job. I enjoy the work.
We've covered a lot of ground, but I think we're kind of out of time. Is there any last? No, you're fine. You're fine. Is there any last key takeaways that you want to leave our listeners with?
Don't use niacin without the assistance of somebody that knows how. And even if they think they know how, you're better off if you contact Dr. Kim, and she can put you in contact with me. And I'm sure she won't mind, because I'm not stealing you. I'm just borrowing you. Niacin's tough to use. I'm good at it. And I love niacin. I take 4.5 grams myself. I'll contact her. What I want you to know, and I'm going to go through these real quick because they're your bullet points. Don't buy into all this smear campaign, niacin bashing. Some of the most famous people never quit using it. They're angry because they know niacin. And most of the people that are against it are idiots. They're clueless. They think they know niacin and they don't. And most of its effects are horribly underestimated, like LP-Lily. Okay. Why do they get it wrong with niacin? Because a lot of money is being made off of drugs that don't work as well. And they can't have some inexpensive vitamin around that could do a better job than a drug that costs 16 grand a year. Praluent and Repatha, if you take the number needed to treat, which I went through, the cost of the therapy and the length of their study to reduce heart attack, it costs $600,000 to $2 million to get rid of a heart attack. Niacin as monotherapy costs $2,000. That's because you have to treat 27 people for 5 years. So what does that mean? That's $5 a month. Duh.
Right.
And that's the average dose, not even a high dose. What are the health concerns? I think we went through that, particularly based on my experience. Niacin benefits almost every disease state. And I'm not sure I have all the answers, but the data is in the literature. Neurological, fatty liver, kidneys. People think niacin's toxic to the liver. Yeah, if you use sustained release and don't know what you're doing. Plain niacin doesn't stay in the liver more than an hour. And if you do it 3 times a day, it cleans the liver out, which is really an interesting thing. It'll correct even the late stage. Fish oil is great for fatty liver, but it won't correct the cirrhosis at the end, the fibrosis. Niacin has an FDA indication for that, but nobody can get the money to get it back to market because of what we mentioned. What are the symptoms of chronic kidney disease? Almost none until it's pretty far gone. You might get uremic breath or frost around your lips, so that's usually right around dialysis time. So don't assume you don't have it. If you have blood pressure, blood sugar issues, especially both, you might have it, but that's not an absolute. Low thyroid, it causes kidney disease. LP-little-a causes kidney disease. So you got to ask for a few biomarkers you might have to pay for. But guess what? For 1/4 the cost of a car payment, you can get fabulous lab work with or without a doctor.
Right.
And if you run it through insurance, if you're lucky, they might only bill you for the biomarkers that they don't want to pay for. And they're always better biomarkers. If you're Medicare, it's easy. I mean, you can run a Boston Heart Diagnostic Panel, and Medicare pays for everything. The genetics require some paperwork and blah, 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 but you can get the sterols. I'm a hyperabsorber. My brother is. It's genetic, 1 out of 4 people. But, you can at least get everything but the sterols through a vendor that will give it to a huge national lab, who I'm not really fond of, but it's about $242, and I've had maybe 100 patients that ordered it. You just need a credit card. Is your life worth $242? I would argue it is. Your car costs a lot more, but you're not going to be driving it much if you get heart disease or you're dead. So get the
Exactly.
word biomarkers. And creatinine is bullshit. I'm sorry I used a bad word, but it is.
Yeah.
You want what they call cystatin C. Tony's lab, I think it's $23. $23 to confirm you do or don't have kidney disease and to tell you with precision where you are instead of waiting for creatinine to tell you when you're ready for dialysis. That's a little late.
Right.
Well, there you go.
Okay.
When should someone see a doctor about kidney disease? Long before you get it.
Right.
Don't
Get
wait
those
for
markers. Get the cisplatin C.
and if he won't order it, contact Dr. Kim or an enlightened provider and say, I want this biomarker, and say, I don't care if I have to pay for it. The problem is, if they don't know how to use it and never ordered it before, they're very unlikely to be willing to order it. Except doctors like Kim, the doctors I hang with, they're cool. They're progressive. They're pushing the envelope rather than sitting in the middle. They're early adopters, not the last guy in line to discover something. And if they're doing anything like integrated, functional, holistic, they're going to be happy to order it. And then if you're going to bother to do that, at the same time, have them determine, and there's a million names for it. It's confusing. MAC, UAC, albuminuria, proteinuria, macroalbumin creatinine ratio. What they're doing is they're catching some urine and they're trying to see how much protein, albumin's in there, whether it's small or large amounts. That will more definitively determine if there's a loss of function. There's only 3 stages. Then A for albumin, 1, A2, A3. If you're A3 and the GFR, which is what they call a filtration term, is based on a creatinine or cystatin C. Well, the cystatin C is the only one you can trust. You might be stage 1 or stage 2. Not too bad, right? But if you're A3, something else is going on and there's structural damage in the kidney so that thin membrane that protects you is starting to lose integrity and protein's leaking. A kidney patient has to eat twice as much protein as a healthy patient because you leak protein. 2 grams per kilogram body weight or 2.2 pounds body weight versus 1 gram for a healthy person. Protein is not bad. It's just been misunderstood. And if you're controlling the phosphorus and the reduction in pH acidosis, well, that's easy to do. I just told you 10 times.
Right.
And it's kind of fun because it's cheap. You beat the insurance company right over the head where they deserve to get hit. And it doesn't affect your insurance or anything. 15 cents a day is a good starting dose. I've got people taking closer to $1, but one in Malaysia, I got off for dialysis. So we had to use a couple other things, methylfolate, methyl B12, which is methylcobalamin, riboflavin, which is great for blood pressure, particularly if you have MTHFR deficiencies. I take riboflavin. I take my own medicine. I don't just talk about it. I'm doing a lot of this stuff. A handful of supplements is not a burden. You just get in the habit. And when you're out eating dinner, they make these tiny little Ziplocs. You can put the niacin and everything in there. A whole day's supply for 3 meals. That way, when you leave the house, something comes up, you get invited to dinner, you went and golfed, and everybody had dinner afterwards. It's always in your wallet or your purse.
Right.
And if you got an Alka-Seltzer next to it, you're good because now you have a hot flash, won't matter. And even if you haven't had a hot flash in years, if you have too many alcoholic drinks, spicy food, sex will bring it on, but you usually don't notice. You got it under control. You've got a weapon to get rid of the hot flash. And the people that have had a hot flash took the Alka-Seltzer, they're very compliant because it's not scary anymore. And it rarely happens once you've been on it for a while. So anything else I can slip in here? What are the most common myths about surrounding lipids? That they're not as important as you would think. That's a myth. It's 70% of the risk for vascular outcomes, including death. And it causes everything else because the first thing that makes the lining of your arteries sick is lipids. And it's usually from eating carbohydrates, not exercising, and genetics. Well, LDL is not your friend. It's going to mislead the doctor. He's going to drive it down and it's not doing much past the lowest dose of the statin. You really want to fix your lipids, take niacin. That doesn't mean it's the only thing I'll use, but I'll add it on or add the statin on at a low dose, but only under certain circumstances. Red yeast rice is just as safe as a statin. Merck tried to get it banned because it was discovered in China 1,000 years ago. But guess what? It's the only statin, and it's natural, God made it, that lowers LP(a) instead of raising it.
Wow, that's good to know.
That's probably good, 23%. I put my wife on it. I got a bunch of LP(a) patients. I didn't know that a year ago, but to your benefit, I read way too much, and some of it's useful information.
Right.
That's when I come up with these ideas. So many people are familiar with LDL, HDL. The best two markers are ApoB, that's APO with a B, and the good guys, ApoA1. If that's in a normal range, that means you have enough good guys and they're not brain dead. They're functional. They work. They're doing their job. You get that up, it offsets an ApoB that's in the yellow, because if your ApoA1 is really high, I see that in women, and they can't take enough niacin or whatever. If I get them close to the ApoB, yellow, and the ApoA1 is really high, do the ratio. If it's 0.6 or less, you're home free.
Okay, good to know.
That's where you want to be. And what else? If you have any time at all. Most lipid disorders, chronic conditions. I went through a lot of that.
Yeah,
you fix the lipids. Yeah. Your whole body benefits by better, closer to normal lipids. And I always like to push them past normal so they got really low risk. Then if something else can't be treated properly or it's an exotic disease, you stand a better chance. I got a kid, well, he's not a kid. I was born with a genetic defect he got from both parents. He's in New Orleans. Boy, I love the food down there. The parents promised me free dinner. I'm going to take him up on that. He's got this weird, unfortunate genetic disorder. He had to get a cochlear implant because he's half deaf. His livers are affected, kidneys affected, heart affected, whole body. Turns out it's at the cellular level. It's the mitochondria. Guess what repairs mitochondria? Begins with N.
Wow.
And it's really good at it. So I got him on niacin. I've got him on methylfolate, methylcobalamin, riboflavin, and of course, sodium bicarb and calcium carbonate. He just turned 20. His kidneys are about one stage away from dialysis. Pretty tragic. I said, please watch him every day he's on therapy for anything unusual. If you're concerned he has a side effect, take him straight to the doctor. But do the right thing, start him at 50 milligrams of niacin, get him up to the point where he's doing a half a gram per meal. And very small doses of niacin are effective with kidneys. And I got a lot of that from Sampath Kumar in India because he uses it a lot. A nephrologist that uses niacin is rare. So if you get kidney disease and you're referred to a nephrologist, ask him if he'd have any issues with niacin. He says, oh, it's horrible. It doesn't work. Doesn't do it.
Yeah.
Next one, go to the next one.
Right.
Besides, ideally, you want a doctor who refers to the nephrologist to be aware of this so he can prevent you from getting worse. And if you go backwards, all my patients go backwards. Some of them go back 100 points, GFR. They were close to dialysis, a GFR of 30. Now they're 130. It's cause and effect. They took the stuff. Well, the ones that take more niacin or took it at all, they went more than a stage. The ones that only did the Tums and Hammer, sodium bicarb, calcium carbonate, they all go back a stage. That's a benefit. That's a miracle. Nobody believes that. But I mentioned my high-powered friends. One of them sits on the NKF, the KDICO. He's a family doctor, but just a lot of publications. He tripped over me on LinkedIn, kind of like Dr. Kim. And it's a cool thing. And he's totally convinced he's going to get IRB. I don't even know really what all that means. And a grant, got to get $1 million to do an IRB study. And we're going to do case studies first. But I got so many doctors that are sitting on the case studies, I just have to beg them again. Please let me go into your electronic records and pull them up. It's easy to find. Creatinine over 1. A code for CKD, which isn't usually used for stage 4. But find the ones that went backwards, because the old code will be there and the new code. And one of them said, I'm not sure how to reverse the code from stage 4 to stage 1. I say, who cares? The patient's going to live a lot longer. My dad lived 14 years.
Wow.
Niacin and fish oil and
Yeah.
sodium calcium carbonate. And he's a cranky old World War II veteran. And the first thing he said when Dave told him he needed dialysis was, I'd rather die than go on dialysis.
Well, it's difficult. That's for sure. Yeah.
The three choices are dialysis when you hit stage 4, transplant if you're really lucky, hospice. Many of them have people they know that were on dialysis. They know how nasty it is, and they've elected to die pleasantly at home.
Mm-hmm.
I get it. So
Yeah.
let's not let any of those three things happen.
Right.
And what else? I don't think there's much else to say. We could always do another podcast if I didn't scare the heck out of everyone. And Dr. Kim.
I appreciate your time and your expertise. And where can everybody follow your work?
Well, I assume you don't have 100,000 people on the podcast, so go ahead and give my email and my mobile number. Mobile's great because it's immediate. People that text me, I get back to them like that. If you email me, I might not see it for like 5 or 10 minutes.
Okay.
But
I can
if
put
you
that.
call me and leave a voicemail, that's usually what happens because it doesn't recognize your number, so it won't show.
Yeah.
Text me first because that'll come through even if you're not in my directory, and then I'll make a little folder with your name on it. But I'm pretty easy to deal with. I'm 5'5", and clearly I'm not very threatening. Like I used to say to doctors, I'm not like your average medical sales rep, pharmaceutical rep. I'm not tall, dark, and handsome. I'm short, furry, and funny. But what I have between my ears might be more beneficial to you and your patients than what those other people tell you. And now I have doctors that won't even talk to their friends who are doctors. No, I'd rather ask you, Steve, because they don't know anything that's happened in the last 10 years. It's not their fault. It's not the doctor's fault. It's the insurance companies have burdened them with way too many patients to see, cut down their salaries. They're not getting rich. It's not their fault. It's the system. The system is working against the patient. The doctor knows it. But if he only survives based on insurance reimbursement, I think they get 11 cents on every dollar they bill out for. If you did transmissions, you'd go broke in a week if people paid you 11% of the bill. But doctors keep plowing ahead. A lot of them quit even though they love practicing medicine. They just hate what the system did to them. And I don't think everybody should go concierge, but it's for people who can afford to pay more.
Right.
I'd like to see some things get put in place so that the indigent patient or the one with no insurance or poor insurance, the underserved, could benefit. That's why I keep trying to help FQHCs and rural clinics, because if they tried my stuff, that's the underserved. There's a lot of ethnic problems there, largely non-white, poor income, poor educational status. But you know what? Supplements are cheap.
Right.
You could bill Medicaid, I think, for a lot of it, have all the stuff in the practice at the point of care, and have somebody I could train show them how to use it. Because it's fun. Boy, when the lipids look amazing and they were garbage before you that, I get a kick out of that. You can't put a price tag on that.
Right.
I mean, I get happy every time. That's why I still do it. And I don't make much doing it, but I'm doing the right thing. I'm doing the Lord's work. I'm still working on, making a fair amount of money for it. So don't worry about that. I don't charge that much. And every patient is allowing me to practice. I used to play music for a living. Well, I gave up 4 years of my adolescence from the age of 12 until I was 16. And then the best gig in the tri-state area, a nightclub owned by the mafia. They hired me because I showed potential. Well, I practice. And when I have a new patient, I get more practice. And they're all a little different. And it's a joy. It's a joy to do, to quote William Costelli. It's a great joy in life. Yeah. I don't care if I'm handsome or rich, or if everybody thinks I'm cool. I like fixing problems. They're like little mountains. When I get to the top, like breathe in and look around and go, yeah, that was cool. I fixed that. And then off I run to the next mountain because there's plenty of problems.
Yeah.
And I may never get rich, but I'm content with what I do because I know it helps people.
Well, thank you so much for your time. And I will link your information in the description. And thanks for being here.
Thank you. God bless you for putting up with me. I'm a handful. I know it. But you managed to deal with me for a whole hour. God bless you.
God bless you too. Thank you.